All right, what's going on, everyone? Picking up right where we left off. Someone described to me this neoplasm.
So it's epidermal, most likely epidermal. See a lot of like buds and maybe some cysts or like pseudocysts, pseudohorn cysts.
Okay, so mostly dermal. There's some areas of keratinization that you're pointing out. Okay, you mentioned there's budding. Okay, so we have some strands and buds. This is
Yeah, this is a
Strands and blue buds.
part of our pink strands blue buds differential. Okay, describe the stroma for me.
it's fibrotic, uh, kind of like amorphous.
Yeah, it has this kind of like amyloid look to it. Amyloidy, fibrotic, amyloid-like.
Those are like our amorphous pink stuff in the dermis differential.
Yeah, this amyloid-like stroma is actually a helpful clue to this entity.
Infundibulocystic BCC.
Infundibulocystic BCC. Well, tell me what this is. Describe this for me.
More attraction. And then
Okay, so there's retraction, and what kind of retraction is there? Tumor stroma, stroma,
tumor stroma.
tumor stroma. Is it palisading?
Mm-hmm.
Keratinizing?
Yep. There's some like keratin pearls. Or would these be more like horn cysts, I guess?
Yeah, they're horns, they're areas of keratinization. So this, someone mentioned it. So it's cystic. It almost looks like you have a follicular neoplasm of the infundibulum, but it's really a basal cell.
This is also infundibulocystic BCC.
Infundibulocystic BCC. But what's different about this? So this actually is an infundibulocystic BCC. In this case, we actually do have the features of basal. We have palisading, we have the retraction, and then we have the similar architecture that we saw before. But notice what's different here. What do we not have?
There's no retraction
There's no retraction.
and no palisading.
Oh, yeah, palisading is really not great for basal either. In fact, this is not a basal.
Is this a basaloid follicular hamartoma?
Yes, yes, it is. Very good. So there's a debate. Some people think basaloid follicular hamartomas and infundibulocystic basals are one and the same. You're not responsible for resolving that debate, but if you're responsible for identifying clear examples of what one would call one and not the other. So in this case, it looks similar. You have these pink strands and blue buds, but you don't have those retraction. You don't have the palisading, and you have your fibrotic stroma. And one thing I was trying to key you into, and this is something on the scope that you can see a lot of times, you can see this amyloidy-like stroma, which can be a helpful clue to infundibulocystic basal cell. I mean, sorry, a helpful clue to basaloid follicular hamartoma. So you want to have a yield sign up. You want to be like, okay, well, it could be a type of basal, but with adnexals, let me just pump the brakes just a bit. I'll pump the brakes. I'll take a look at the adnexal neoplasm. Does the stroma really match for basal? Is it retracting like a basal would? Is it palisading like a basal would? And in this case, the answer to those questions is really no, no, and no. And so this is really a hamartoma. Now there's some debate about whether we should call these hamartomas or not, or basaloid follicular adenomas, but that's a whole, you're not responsible for that. What about this one?
It looks like BCC, but the pinkish type.
Yeah. Also have these pink strands and blue buds, right? Pink strands, blue buds,
With the
fibro.
anastomosing.
Yeah, anastomosing, exactly. All right, you guys know this one. Fibrostroma. Good. What about this?
Sorry, Avi, what was the answer to that last one?
Oh, that was a pink. They said pincus. They're correct. That was this one was a fibroepithelioma pincus. Also part of your pink strands, blue buds differential. You can even see that here. Here's the pink strands anastomosing, and when they bud, notice how the buds are a little bit bluer, and you can even see some palisading reminiscent of basal. But it's different. The stroma is more fibrotic, and it's look how interloculated. Look how anastomosing those strands are. So where is this biopsy from?
Volar,
Yeah,
lingual lucidum.
yeah, volar skin. What's going on? Well, you can see already where the abnormality is, because this is normal relatively, and this is clearly not normal.
Looks verrucous.
Yeah, I agree. It looks verrucous. Does it look like just a typical Myrmecia wart? Like a wart on the foot?
No.
No. Okay, so what does it look like? You can describe it.
I'm guessing it's a verrucous carcinoma, but I don't necessarily see where the atypia.
You don't necessarily see where the
Yes.
atypia and verrucous carcinoma. Well, that's a good thing. That's good. Do you know why?
Because there is none.
There is no, exactly. Verrucous carcinomas are pretty bland. There's very little atypia in verrucous carcinomas. But what do verrucous carcinomas have? Look at this border.
Bulldozing into the basal wall.
Yeah, it's got this pushing border. So you can see some features of wart on the outside. You see these round parakeratosis, tears of parakeratosis. You see your coilocytic change. Fine, fine. But then you get these round, bulbous, pushing border projections into your dermis. And what about where the junction of the tumor and the dermis of that pushing border is? What do you see? Like just what's here?
Lymphocytes. Inflammatory. Right.
Yeah, inflammatory. And so some people have described that at that border between your pushing border and your dermis, you can see an inflammatory, slightly edematous area. And you can kind of see that, this area is slightly more edematous than this more fibrotic area, and there's a lot more inflammation there. That's another finding that's been described in verrucous carcinoma. But yes, this is way too much for just any old wart, and good pickup on the lack of atypia. The verrucous carcinomas should not have much atypia. They're pretty bland.
Can I ask a question?
Yeah.
So it's true that with a regular wart, you can kind of like draw a line. It like grows upward, not downward, even though it looks like it's growing downward. Like if you could draw a line and see that it's all starting from the same place, right? It grows upward. So you mentioned that these are pushing down into the dermis. Is
Yes.
that different? Are they actually growing down? And
Well,
that's
let's take a look at the normal. So here's normal. Let's see if I can draw a line here. Now the specimen itself is warped.
Mhm.
If we were to flatten this out, look at the level of the reedy over here. And then look at the level of the reedy compared to if we were to just keep drawing this line straight. So you tell me, is it pushing into the dermis?
Yeah, I mean, based on the line you drew, but like, how did you determine that was where the line should go?
Well, I just followed where from the normal. Here's normal.
Like, I feel like you have to, oh, you
We
have to
just kept the line going. All right, so well, if this is normal, it should be at this level, right? Then if I were to draw a straight line through, it should continue and it shouldn't be below that.
I hear you.
But you can even see though these, look at how far they're starting up and how far they're going down. I mean, this is way too much for just a normal wart. When you see, you'll see a lot of warts if you go to the scope and Dermpath, and they don't look like this. They don't have this like massive papilla that is just bulging into the dermis. In fact, a lot of warts sometimes you see look more like this normal skin, like a flat wart on the foot or something. And you can torture yourself into thinking this granulosis is part of the wart, and there may be even some coilocytic change over here. Normal warts look a lot more like this than they'll do like this. Now, there are some other features we didn't see that they are in the here, such as the rounded parakeratosis and such. But this is way too much for a normal wart. What about this?
So it looks like a follicular tumor. We have a lot of anagen hair follicles surrounding like that central area.
Yep.
We don't see the central pore, but I think this would be like a trichofolliculoma.
Yeah. And we know that this is real hair making because we can see the what kind of granules over here. It's like we just were having this. What kind of granules are in here?
Rhode Island.
Trichohyland granules. Okay. And this is, by the way, usually how they test it. They usually don't give you that central cystic structure because if I had to speculate, they think it's too easy. It's like, I'm not going to give you the central cystic structure. I'm just going to give you a side cut. That's how I'm going to test it. So here, it's more obvious, right? You can confirm this is hair making, you see your trichohyland granules, and then you can see your central cystic structure. But that's usually not how they test it. They usually test
Benign or
trichofollicular.
malignant? Sorry to interrupt.
Yeah,
This is benign, right?
they are benign.
Yeah. Okay.
And in fact, look how see that circumscription? So they are benign. The key point of this is just be able to, what I want to stress is be able to recognize trichofolliculomas when you don't have that cystic structure, which you all did. So great, good job. What about this one?
Like craterform, keratinous material.
With some neutrophilic infiltrator abscesses at the top.
Let's see. Well, there is, for lack of a better word, schmutz in here. There may be some bacterial colonies, but this is in the crater over here. What about, what do we see over here? So there's a dilation. What about here?
I see a lot of acanthosis. If you're mentioned there's a dilation, I'm guessing it's probably either Pallas's acanthoma versus maybe some other differentials. I don't know.
What's your differential for pilocytic acanthoma? There's like one major one.
Dilated point.
Okay, yeah, dilated pore Weiner. And how do we tell those apart?
I think it's the Pallas's acanthoma has like thicker acanthosis change.
That, yes, the bulbosity. Whereas the dilated pore Weiner has just that reedy, that thinner reedy pattern. Okay, so we recognize that there's a pore. We recognized that it has a reedy structure to it. So we have that differential. Which one is it?
Pallas's acanthoma.
What about this one?
Deep how? Or
Pilocytic.
dilated. That's also Pallas's.
Well, what about, by the way, when I say what about this one, it doesn't mean you got the previous one right. So which one has more bulbosity, this one or the previous one?
I think this one looks more like Pallas's ankle.
Yeah,
Pallas's.
and why?
You basically delineate the shape of the
What am I stressing? What's the difference between this and this?
Yeah, the really here are really bulbous. So this
The
is
reedy are massively bulbous.
this is the Pallas,
Yes.
and the other one was the dilated pore.
Each one of these reedy are big, massive bulbous structures. If you compare that to this one, what are the these reedy are tiny. These are like little thin little strands in comparison. So this is a what?
This is your dilated pore Weiner.
Yeah. Good. And Shane says pale cells and sebaceous duct also better for pilocytic acanthoma. Yes. Everyone see how those cells are paler? That also goes with pilocytic acanthoma. What about this one?
It looks like sebaceous hyperplasia.
Okay, so there's definitely large sebaceous glands. Is there anything else?
There's a cyst. Trying to see the wall of the cyst.
Just the cyst, and in this case, it's actually connected to the sebaceous gland. So there are a lot of sebaceous glands. There's a cystic structure. Is there anything else? What's the stroma like?
Fibrous.
Yeah, there's a fibrostroma here. More here. It's fairly sizable. So, do we want to just call this sebaceous hyperplasia?
No, it's more than that.
More than that. Okay. Is there anything like completely abnormal or messed up about these sebaceous glands?
I think they look pretty well differentiated.
Yeah, they're pretty normal. It's just like there's too much of them and there's too much of these structures. So it's just too much of a good thing. What do we call too much of a good thing?
Hamartoma.
Hamartomas. Too much of a good thing. It's not cancer or anything. It's just not a. It's just making too much of these normal structures. So what kind of hamartoma were we thinking? Well, we have follicular structures, sebaceous structures, the cyst. Is there a hamartoma that has all those things?
Oh, it's like you just named it, the
Yeah,
follicular
like
sebaceous cystic
cystic
sarcoma.
hamartoma.
Yeah, follicular cyst. Okay, good. Sebaceous cystic hamartoma. So yeah, it just that's what that's just that entity that it looks like. Once it's sort of lower yield, but once in a blue moon, you might see that on one of your exams. As opposed to this, which you definitely have to know. So what kind of, how are we going to go about describing this neoplasm?
So there are groupings of blue cells with peripheral palisading. There's also retraction. But it's like stroma retraction, I would say.
There's some stroma retraction. It's not quite, I'm not seeing it quite palisading the way a basal would. There is some palisading
Yeah.
over here. So what are we thinking these structures are? In fact, there's a little bit of this here.
Hair follicles?
Yeah, they're follicular structures. What kind of stroma is this?
Fibrotic.
Follicular structures in a fibrotic stroma with these cords of epithelial lining follicular cords of epithelium penetrating the fibrous stroma.
The fibrofolliculoma.
Fibrofolliculoma. Okay, good. And if a patient has one of these, what are we thinking?
Just like a benign hematoma, spontaneous.
Benign fibrofolliculoma. Don't worry about it. One thing. What if they have a whole lot of them?
Hog Dubé.
Bird hug dubé, yeah.
Okay, tell me about bird. What's the deal with bird hog dubé?
They have fibrofolliculomas, acrocordons, trichodiscomas.
Okay.
It's
So
a mutation in the folliculin gene.
folliculin mutation. Okay. And what else? What else happens to them?
They get a bunch of cancers like renal cell carcinoma.
What kind?
Um,
What kind of renal cell is the most common in bird hog dubé?
carcinoma?
I think
Well, it is it's an oncocytoma.
No.
That's the most common one in bird hog debate. Okay. Okay. And what else pulmonary wise, what happens?
Spontaneous pneumothorax from pulmonary cyst.
Good. Now, one thing you mentioned was a trichodiscoma. What's the difference between a fibrofolliculoma and a trichodiscoma?
Trick question, there is none.
Okay. So like if you imagine if I section this specimen like this at an angle, right? Yeah. And I missed all of our cords of epithelium. And I got this hair follicle at the side. Imagine we'll get something like this. Here's our follicular structures at the side. Here's the cords. We missed all the epithelium. But that's a trichodiscoma. A similar story here. We see our follicular structure at the side. Here we just see our fibrous orb. In this case, we have a central follicular structure. So there are a lot of people think at this point in the meta of trichodiscomas versus trichofolliculomas that they're basically one and the same and that you're just cutting it at a different angle. What about this?
Looks like more sebaceous glands.
Sebaceous glands. Yeah.
Too many.
They're pretty large.
Symmetrical though.
Yep. Not a whole lot else going on. What do you want to call it?
Was it some kind of sebaceous tumor?
Sebaceous height.
Sebaceous
No.
hyperplasia. That's it.
Yeah.
Don't, if it doesn't look too complicated, don't make it too complicated. This is just sebaceous hyperplasia. As opposed to this, which is a little more complicated. So what kind of differentiation?
Sebaceous.
Sebaceous. Everyone sees. And how do we know it's sebaceous differentiation?
You see those like scalloped nuclei.
Yeah. Yeah, it's crenating the nucleus. It's, or some people call it rat-bitten nuclei. It has a mass effect on the nucleus. Unlike glycogen, which usually doesn't really have as much of a mass effect on the nucleus, fat has this mass effect on the nucleus. Okay. So, benign or malignant?
Malignant.
Why do we say malignant? What are the three things we'll look for in low power to judge benignity versus malignancy?
Symmetry.
Okay.
Circumscription.
Okay, well let's do circumscription. So is it circumscribed?
Yes.
Very
Yeah.
well circumscribed.
Yeah, but
Okay.
it's so ugly.
Do we see any atypia or mitotic figures?
So not as much. So there may be some mitotic figures because remember there are some of these more primitive cells, but nothing abnormal for this entity. If you just saw this area, what would you call this sebaceous neoplasm?
Sebaceous adenoma.
Okay. And if you just saw this area, what would you call the sebaceous neoplasm? Wait, sorry. Yeah. So remember, if I'm asking you the second one, it doesn't mean you got the first one right.
So there's sebaceous adenomas and sebaceous epithelium when it's greater or less than 50%. Like
Okay, so which one is this? Is this greater? Which one is more than 50%?
sebaceous adenoma.
Okay, and now let's go back to this one.
That one looks like more than 50%.
So what's this one?
Less than, so this would be like a sebaceous epithelioma.
Yeah, and what's another name for sebaceous epithelioma?
Sebaceoma.
Sebaceoma. Good. Sebaceoma or sebaceous epithelium. Now, in this case, if we're going to now, the question is, and I only I'm doing this because they will ask you to differentiate this on the exam. Take the whole lesion together as one. What are we calling it?
Sebaceoma? Or sebaceous adenoma?
Well, it's one of those two. I agree. So let's say both of those options are on the test.
Sebaceoma.
So you think 50% plus are the blue cells, and
No, let's go with sebaceous adenoma.
probably around 60-40. Terrible question. Yeah, this is sebaceous adenoma. This was called a sebaceous adenoma.
So just to clarify, sebaceoma and sebaceous epithelioma are synonymous.
Synonymous.
Okay.
Yes. As opposed to sebaceous adenoma, where the over 50% are these clear cells with the fat. Okay, what differentiation?
Sebaceous.
Definitely sebaceous. Okay. Benign or malignant?
Benign.
Okay,
Yeah.
good. And well, we're gonna make the same call, right?
Gonna be more
Adenoma.
epithelial cells, so sebaceous epithelioma.
Yeah, or sebaceoma. Good. Okay. Now what's going on here? Well, first off, before we even get to the differentiation, benign or malignant?
Malignant.
Okay, good. You see, like, here's a chunk here. Somehow another chunk got all the way down here. Part of it, whole bunch of it is necrosed. Okay, so we're worried about some kind of malignant process here, and it's huge. Okay, what's the differentiation?
Sebaceous carcinoma.
Yeah, sebaceous. Yeah, so this is definitely sebaceous, and this probably is a sebaceous carcinoma. In fact, it's quite a bit. It's very architecturally complex. It's very large. It's going very deep. There's in areas over here, there's also necrosis on moss. So there's large areas where the tumor has outgrown its blood supply and it's dead. Now, there are some benign entities where that can happen as well. But this is really too much. There's also, if you, and the other thing we're looking for, tell me about the cells themselves. You see how any difference between the cells, see if we can find differences between the cells. If we were to just look at the cells here of these benign. Okay, get a good look at that. That's normal. What's different about these nuclei? Or these nuclei, if I go down to the...
They're like really like hyperchromatic, and you really don't see like the scalloping or like that we see in like the previous ones. They're like
In
really
some areas you
condensed.
do, but yes, I agree. There's areas of that there's a lot more hyperchromasia. I agree with that. And in some cases, you can see more mitoses, and you can see more pleomorphism. So there's cytologic atypia to this. That's another thing to look for sebaceous carcinoma versus sebaceoma. But yes, you guys got it. All of those low power findings. You guys nailed, and you guys noticed that this is going. It's large. It's going deep. Has necrosis on moss, and cytologic atypia. And actually, Shane mentioned the cytologic atypia. What about this one, guys?
Do we see, would you call this a paisley tie pattern?
Well, I can see why you say not quite. I mean, this tumor it has cysts and it's keratinizing, but it's more than just a paisley tie. It's like, what's all this?
So, I mean, some of those areas kind of look like BCC, like, but then I was like retraction.
Is it a trichoepithelioma?
Good. And why is it a trichoepithelioma?
It looks like the classic one. You have this, you have the cyst, but you also have kind of like those lobules. And
Okay,
the
so it's keratinizing. Okay, so better for trichoepithelioma than trichoblastoma. And it has these, yes, it looks like a follicular neoplasm. It has a fibrostroma. And, you notice this retraction, but really this is what? Like, what is this structure?
papillary mesenchymal
It's
body.
a papillary mesenchymal body. See the ball and claw? So papillary mesenchymal bodies are another structure that go for trichoepithelioma. As opposed to, and well, notice the lack of not as much keratinizing over here, and it's going deeper. Similar stroma though, right? What's the stroma on this one? Is it fibrous? Is it myxoid? Is it, what's the stroma?
Fibrous.
Fibrous. There's a fibrous stroma. with these islands of cells.
This looks like trichoblastoma or
Yes.
No.
Yes, this looks exactly like a trichoblastoma. In fact, it is a trichoblastoma. So it's similar. Notice that the stroma is quite similar. Both have a fibrous stroma. What's different, the trichoepithelioma is more keratinizing than the trichoblastoma. Trichoblastomas also go a little bit deeper, typically. At least that's the way they like to test them. You can see some areas that it may even resemble. I find it easier to find papillary mesenchymal bodies in trichoepitheliomas than trichoblast, at least the classic ones, in trichoepitheliomas and trichoblastomas. But yes, that's the main difference there. We're at this one. What about this one? Well, what do you see?
So there's like a obviously dermal tumor, and those cells don't, as opposed to what we were looking at before, don't look so much like keratinocytes.
Okay, what cells are you seeing?
It kind of just look like lymphocytes.
There's lymphocytes. And where are the lymphocytes? Like, what's surrounding? You see this thing surrounding the lymphocytes?
They're like a fibrous stroma surrounding,
Not just the fibrous-stroma. Look at this lining. Look at this.
like an epithelial lining.
There's a cells that are lining this area, and in this area, they're peppered with lymphocytes. Similar stroma, though. What's your stroma?
Fibrous.
Similar stroma to that trichoblastoma we just saw. So what kind of neoplasm has these structures? It looks like it has some follicular germ here, like it has some reminiscence of the trichoepithelioma we just saw, or trichoblastoma we just saw. But this pattern is different. It has this cleared out pattern where the cells are really at the sides and they're peppered with lymphocytes in between. Otherwise, same stroma. So this is called a cutaneous lymphadenoma. And there's another name for it. It's called adamantinoid trichoblastoma. That's the older name. But you are responsible for either name. That's another annoying thing that the courts do. So if they say cutaneous lymphadenoma, you're responsible for cutaneous lymphadenoma. If they say adamantinoid trichoblastoma, sometimes they're mean and they use those old language terms that have fallen out of favor. You got to know that one too. Okay. What's your differential for this?
Is this rolls and scrolls?
Rolls and scrolls. Yeah.
Something like proliferating tricholemmal or pilocyst.
Proliferating pilar or proliferating pilar cyst. Okay, there's one other thing that can look similar to this at low power, but it's not this at low power in this case. What's one other thing on your differential?
Pilometrics coma.
Yeah, pilometric coma could have this type of cystic aggregate, and we'll see that in a minute. But yes, in this case, you're absolutely right. This is a proliferating pilar cyst. Whereas this, we can already see the tissue here.
This is more pilomatricoma.
Yeah, it has that salmon color resembling those ghost cells, and we can even see them over here. Good.
Oh, so that's how you made that differentiation obvious, that like that salmon color, you know, that there's
We
ghost
also and
cells
we
there.
also see the transition. So look, even from lower pilar, there's also this other thing I'm seeing. I'm seeing these areas now. Proliferating pilars can calcify, so I'm going to go in here, but I'm suspicious this might be matrical tissue. And I'm going in, and then I see, oh look, you see, everyone see this as transition. This area,
Yeah.
this area, they're dying, and now they're dead. Right? So what do we call these cells?
Ghost
Those
cells.
are your ghost cells. But
Ghost
then
cells.
but this can also be like ghost cells has multiple different meanings depending on what entity it is that you're looking at, right? Like there's ghost cells in the context of pilomatricoma, but there's also ghost cells for like, oh god, is it like paniculitis or like
What do we call what context is it when we have matrical tissue dying into ghost cells? There's only one. It's this one, pilomatricoma. Or pilomatrical differentiation.
uh-huh.
What are some of the conditions associated with pilomatricoma, by the way?
Rubens and Tabi.
Rubens and Tabi, okay. What else? It's like 4 you're responsible for.
Oh
Garner.
crap.
Turner syndrome.
Turner, Rubens and Tabi. One more.
Is it myotonic
Good.
dystrophy?
Myotonic dystrophy. What about this? To describe it.
There's horn cysts. Seems like there's some acanthosis, some solar elastosis as well.
Okay.
And is this mucin? Looking these like is it pools of
Well,
mucin?
you tell me, is it mucin or are they solar elastosis?
Oh, that's solar elastosis.
And
And
this is, and what about this? What's this?
Ink.
Ink. Good. Okay. All right. So solar elastosis, but there's the neoplasm here.
It's displaying endophytic growth. I don't know, maybe it's a squamous eddy, some
Yeah, squamous eddies. That's
Yeah.
exactly what these are.
I this entity I think it is, I'm really confused because I only can think of one picture of it and it's an Elston and it's like I think it confuses me. That inverted follicular whatever keratosis.
Yeah, IFK, that's exactly what this is. Inverted follicular keratosis. So it kind of looks like a seb, but it's more upside down than it is right side up. The way I kind of think of it. See how it's like normally we have sebs protruding outward. This is more protruding inward, if anything. More so here. But it has an architecture otherwise. It has the squamous eddies. It has even pseudohorn cysts. And this has a completely benign silhouette.
Do you usually see solar elastosis in the background of this?
People with sun damage can get all sorts of things. They can get sebs. They can get IFKs. Solar elastosis is a clue for certain things, so we wouldn't be surprised if he had a squame, and we wouldn't be surprised if he had an AK. But would we be surprised if someone with solar elastosis had a seb? Not really. Would we be surprised if he had a IFK? Not really. What about this one?
Warty dyskeratoma.
What do we see in warty dyskeratomas?
Like this verrucous, uh like almost like volcanic like nodule with atypia.
So cup-shaped, verrucous. There's a feature in there that you didn't mention.
Lysis.
Not just acantholysis, but
Lytic.
acantholytic dyskeratosis. Do we see that here?
No.
What do we see here?
The base reminds me of like a tricholamoma.
Yes, it reminds you of a tricholamoma. Do you know why it reminds you of a tricholamoma?
As it is one.
Because it is one. Yes, exactly. Okay, so why is
Oh,
it
these are warty too. So like they often get
Yeah.
confused for warts.
Yep. These are also warty. Now, you're not responsible to resolve the debate if these actually are warts. There's a whole debate about whether, there's some data that stains us for HPV, and like, oh yeah, we found something, and there's some other data that stains us for HPV. Like, what are you talking about? It's completely negative for HPV. You guys don't know what you're talking about. It's not a real wart. You don't have to know the pathophysiology to answer the question if it's you're not responsible to resolve that debate if it's really a true wart or not. But you do have to recognize it. So why is this a tricholamoma? Well, what are the features that we're seeing? So some features you already mentioned, it's verrucous, right?
Yeah.
I think the cell is like a kind of like paler because of glycogen.
Paler, and it's kind of getting paler as you go down. And what do you also see on the way down?
Peripheral palisading.
Yeah, it's palisading also over here. It's verrucous. It has an outer root sheath differentiation. See that? Has that peripheral palisading. Fibrovascular stroma. What about this one?
That looks ugly.
I disagree. I think it looks beautiful.
I think it looks malignant
Why do you think it looks malignant?
because
Let's
it's
go
not
through our low
symmetric.
powers. Size, symmetry, circumscription.
I don't see the symmetry here.
Size, okay. Let's go through size first. How's the size?
It's circumscribed.
Okay, it is circumscribed, and the size is not that big. And nothing is perfectly symmetrical. There's stroma here where it's not there, but overall, what about atypia? Do you see any like frank atypia, mitosis, pleomorphism? Any nuclei that are like awfully hyperchromatic?
I guess not.
Okay. So why did it look so ugly?
Because
Was it
the actual
of this?
tumor is not the actual portion of the tumor is not symmetric. There's
Well, it's not perfectly symmetrical, but look, here it's got some areas coming out here. All right, here's got an area coming out here, just like it did on the other side. It's got a center. And it has this area, which has a similar type of differentiation we saw earlier. So if I were to draw a line between this, it's not perfectly symmetrical, but actually overall it's not that asymmetric. We got an arm here, we got an arm there, we got a leg here, a leg there, we got this span over here. So it's not crazy asymmetric.
okay.
But what do we but just also these are heuristics. So like if we have something that's low in size, something that's well circumscribed, but it's not, the symmetry is a bit off. Don't pull the gun on malignant. They're rules of thumb, and if you have 2 of the 3 rules of thumb that are going for benign and 1 going for malignant, let's look. You might look at some other features before we just make a call on whether it's benign or malignant. But let's talk about what this might be.
Is that like a mixed tumor? I feel like
What do we see in mixed tumors?
so there was like stroma versus epithelial structure. So I saw some like hyaline, like a pale gray colorish materials here. I don't know if that's like a conjure, but it's probably not. I guess
Kind of material? This material? This area?
yeah.
What kind of material do you think this is? Do you see any
Oh,
like
you-
chondroid differentiation?
This is mixoid.
It's myxoid stroma. This is an area of more myxoid stroma, and this area of more hyalinized stroma. But do you see any like ductal structures like you could see in a mixed tumor?
No,
Okay.
probably not. Yeah.
What do you see over here?
Is that palisading?
Yeah, there is peripheral palisading. And what about here?
You're talking about like the cells with glycogen.
Yeah. And if we just go back to this example, what did we see?
Very similar.
The same thing.
Oh,
Yes. Peripheral palisading. All this glycogenated area is more glycogenated as you go down the tumor. As we go further down, it's more outer root sheath differentiation.
so this is a trichomoma, but just less warty at the surface.
What's different about this trichomoma? What's off with the stroma? How would we describe the stroma?
It's degenerated. The myxoid
Okay.
degeneration and
It's
the
it's hyalinized. Like another word is desmoplastic. Fibrod. It's the word. I think the etymology of desmoplastic is desmos. Anyone know desmoplastic or desmos? Anyway, this is the reason why it looked ugly to you. It looked ugly to you because it has this area of desmoplasia. And that's why the stroma was off. This looked fine to you because it didn't have that. But really, this is just the same thing. It's just this area. Now imagine I put a bunch of hyalinized stroma in here. If I put a bunch of desmoplastic stroma, what would it look like? Kind of like this. So what do we call it?
Desmoplastic trichomoma.
Desmoplastic trichomoma. And by the way, where do we see trichomomas and desmoplastic trichomomas?
Cowden syndrome.
Cowden syndrome. What's Cowden syndrome?
It's like a P10
Yeah.
it's like a P10 mutational thing. You get like colon cancer, you get follicular thyroid carcinoma.
Carcinoma of the thyroid, colon cancer. Are those the most common cancers, by the way?
breast cancer.
Breast
cancer
cancer
is,
is the
yeah.
most common. Thyroid cancer is second most common.
Do you get BCCs also? Am I confusing with something else?
Squamous cell carcinoma is the third most common cancer.
Squamous. Okay.
Yeah.
Then colon, uterus, and others. Okay. What about this one?
I see like huge blue cell tumor in the dermis, with some eosinophilic change in the center.
I think these are just blood. But there are actually some eosinophilic areas that are not blood, actually, you're right. And here too. Look at this. So what's this?
Is that a desmoplastic stroma?
Desmoplastic stroma. Yes. Desmoplastic stroma in a
Tricholamoma.
trichomoma. You guys are
Desmoplastic.
getting good at this. What is it?
Desmoplastic tricholamoma.
Yeah. Now, in this case, also, as Shane pointed out, there was an area of necrosis on moss over here. So don't jump the gun and say, oh, if there's necrosis on moss, it must be cancer. Because there are certain benign tumors that can also have necrosis on moss. But yeah, so this is, I don't know if you were referring to this thing or you were referring to these things. But
Yes,
this
that's
is the
what I'm pointing, like and like center, like a red.
Oh, yeah, no, this is just the necrosis on moss. That's just dead cells that have outgrown it. This area is the desmoplastic stroma. This area is the necrosis on moss. You see the difference?
Yeah.
And this one?
There's like a lot of cracking of the tissue. I feel like that pale pink. Actually,
Is that hyaline cartilage? Like, is this a mixed tumor?
Well, you tell me, is this hyaline cartilage?
It looks like chondroid. I mean, to me, I don't know.
First of all, let's talk about the color. What color is chondroid?
Oh, chondroid is actually pale blue. Sorry,
Bluish. What color is this?
like pink, light pink.
Yeah, and these have, and you know, there are lacunae and chondrocytes as well. There's something else that this is like a lightish, much more lightish kind of pink structure. It's more organized as well. Doesn't look like there are chondrocytes here, or chondroblasts. But let's take a step back. All right, guys. Benign or malignant?
Benign.
Benign. Quite benign.
Yeah.
Okay, this
Right.
thing shelled out. Okay. So what's our pattern here? It's something similar to what we saw before.
It kind of reminds you of the rolls and scrolls.
Yeah, kind of does look like the rolls and scrolls. What's your differential for rolls and scrolls?
Proliferating pilar cyst
Versus?
and pilomatricoma.
Okay. So presumably we would look for something like this, right?
Ghost cells.
Yeah.
Those are ghost cells.
So what was this? What were these things then?
It looks like bone.
Bone. Yeah. It's bone. And so is that normal? Can we get bone in these things?
Yes.
Yeah, because it's all
Yes.
calcium.
Yes, it can bona fide. Yes, in fact, at Mount Sinai, all of our specimens are actually bona fide, or at least some of them. So this is a bona fide pilomatricome. So in some cases, pilomatricomas can be, if you leave them alone, the pilomatricomas may not have any matrical tissue left. And sometimes they're so burnt out that all you see is the residual ghost cells, and you may not have any matrical tissue to make the diagnosis of pilomatricoma, and that's okay. You don't need matrical tissue left over. You can have a burnt out pilomatricoma. Bona fide or bone afide. Bona fide. Okay. I'm glad someone appreciates those terrible jokes. All right, what about this one?
kind of just looks like normal scalp.
Okay, it is scalp. What's going on with the scalp?
I mean, we see a lot of sebaceous glands, I guess more so than you would normally see.
Mm-hmm.
So scalp, sebaceous glands, like nevus sebaceous.
Okay, and why is it an sebaceous?
Um, we have terminal follicles.
Yeah, look at what we're missing in the middle here.
Oh yeah, you're missing all the terminal follicles.
We have no hairs.
Yeah.
Sometimes you might find apocrine glands here. And it's papillomatous. And it has sebaceous. So it's bold, it's broad, it's bumpy, and it's bubbly. Bold, broad, bumpy, and bubbly. Now, it's not as bumpy and it's not as bubbly prior to puberty, but it is bumpy, but it is more bubbly right at birth. Why is that?
Is it because
All the
puberty?
like hormones.
Yeah.
Okay, yes. So the maternal androgens in utero will develop these sebaceous glands. And so it'll have that kind of appearance in nevus sebaceous at birth. That will regress because they haven't hit puberty yet, and so they don't have those androgens. And then when they hit puberty, they'll hypertrophy again. So it has multiple stages as we go through life, the nevus sebaceous. What about this thing?
Trichoadenoma.
Trichoadenoma. Okay, I think you guys know that pretty well. You get your toasted oats, trichoadenoma. Okay, well, this looks similar to that, but what about this one?
I think this papillary adenoma versus tubular. There's like, they're basically the same thing. But I think this has like a secretion and decapitation.
So is it ecrine then?
I think this is more like apocrine.
Good. Good. More decapitation secretion.
Oh, less papillary, I think. Yeah, this is tubulary apocrine added.
Yeah, this is a tubular apocrine adenoma. Good. As opposed to this, which is a
This is more papillary acrine adenoma.
so has the same tubular structure. What's the secretion?
Ser Sweat.
Yes. And is it apocrine or ecrine? Ecrine. So, not a surprise. I put a tubular ecrine adenoma right after a tubular apocrine adenoma. We're getting to the end, just a few more. Big neoplasm, right?
Yeah.
Oh, that's a good point. Shane's saying they just lump them all together under tubular adenoma because there's overlap. So they don't differentiate tubular apocrine versus tubular ecrine. All right, maybe you might not be responsible for that then. Hopefully not.
Hallelujah.
What about this thing? Now this thing is clearly what type of neoplasm? What kind of category are we in?
Follicular.
Good. Definitely follicular. What made you say follicular?
It's a lot of keratinizing material.
Keratinizing, and what are we differentiating towards? Does it remind you of any normal part of the hair?
Matrix?
Okay, there's symmetrical material here. What else is there?
What, trichohyalin?
There are some areas, so I could find some. There are some areas of trichohyalin in this entity. Okay, well, you're mentioning a number of things now. You mentioned matrix, you mentioned trichohyalin, some granules. There's also, what is this? Does this look anything familiar that what we saw before? In fact, let me see if I can find it.
Palisade.
Palisading, okay. And we mentioned it a couple of times. What's that palisading glycogenated area?
Melanoma.
Okay, it's,
Alveolar sheath
well,
type.
specifically, where does it differentiating towards?
What's like alveolar sheath?
Outer root sheath. So this is, you basically are naming all a differentiation toward all the different structures of the hair in a big tumor. So what tumor differentiates toward all portions of the hair?
Is that panfollicular?
Yeah, panfollicule.
Uh, I don't remember the name.
Oma.
Oma, a panfolliculoma. You got it. We got there. Okay. Yes, this is a panfolliculoma. Okay, so yes, it differentiates towards all the different parts of the hair follicle. Now, someone mentions a differential that this might be in.
Tadpole, paisley tadpole.
Tadpole. What is your tadpole differential?
Desmoplastic trichoep,
Okay.
morphiiform basal,
Okay.
MAC.
Yep.
This is the carcinoma. Um,
Syringoma.
Syringoma.
Syringoma. Okay. So in this case, are we keratinizing?
Yes.
Yes. Okay, so there are cysts. And let's talk, is it, one thing we mentioned, MAC. So is this a MAC?
No.
No. Right,
It's
look
well
at that
circumscribed.
Not really going deep, fairly well circumscribed. So max out. What's this?
Sebaceous gland.
Calcification.
Calcification. Okay,
Mm.
good. So there's areas of calcification, and how's your stroma?
Fibrous.
Fibrous.
Yeah, quite fibrous.
Desmoplastic
It might even
trichoepithelioma.
say desmoplastic. So what's your diagnosis?
Desmoplastic trichoepithelioma.
And what's our epi look like over here?
Hyperkeratotic.
There is hyperkeratosis.
It's very vacular. A lot
Yeah.
of
Yeah.
vac
It's very vaculated. What's the differentiation?
Poorly differentiated.
Well,
Actually, no, it's a sebaceous differentiation.
Sebaceous differentiation. I agree with sebaceous differentiation. I also agree with poorly differentiated. Well, we can talk about that word poorly differentiated, but like it's interesting because there's sebaceous. There's an in situ component here in the sebaceous neoplasm. And what kind of pattern is it when these vacuolated cells are coming up?
Agitoid.
Yeah. Can sebaceous,
Yeah.
yeah, so what?
Periocular sebaceous
Yeah, they can
carcinoma.
exhibit sebaceous. So sebaceous carcinomas, can they do pagetoid extension?
Yeah.
They can, yes. And what do you want to stain this with if you wanted to make sure? Like you'd have a whole differential for your, I mean, there's pagetoid cells here, I mean, right? Like you got to work this up.
So
That's
you want to
good.
stay in the
Okay.
Like CK7, CK20, or
Okay, for Paget's, you worried if you worried about Paget's? Extra memory
S100,
cards?
Flex 10.
LMUs.
I'm sorry, everyone's too.
Busen, Deepers,
Okay.
712, CK7,
Okay.
CK20.
All right, let's keep it organized. Okay, so if we're thinking just to rule out a melanoma, let's do what? If you wanted to make
Flex 10. S100.
Yes, S1.
okay, fine.
HMB45, Melon
You know your
A.
melon, your melon markers. Okay, so you mentioned your keratin stains for this was a squame. You mentioned your stains for extramedullary Paget's. What about sebaceous neoplasms?
CEA.
EMA,
Okay.
CA.
Yeah,
Adipophilin.
adipophilin. Good.
Dr.
Okay. All right. Good job, guys. So this is a sebaceous. So just remember, sebaceous carcinomas can also do pagetoid. In some cases, they can exhibit pagetoid spread. So that is technically on the differential for pagetoid cells and pagetoid pattern. All right. Good job, guys.
Thank you.
Well, good night, everyone.
Thanks, Avi.
Thank you.